Thanks, man. And that concludes our lecture for today. Okay, there's a lot of folks here, but what I like to do usually is go around the room and ask people 3 questions just so I get a feel for who I'm talking with. So I think what we'll do today is I'm just going to pick out maybe 3 tables and just go around the tables and just ask you to tell us your first name, how you got here, other than maybe by car, and lastly, in a sentence, just what you want to get out of today. Okay? So let's start closest to me.
I'm here against violence, sexual violence, and I was invited by someone to the previous Constructive lecture series, and I came up with it. And what I hope to get out of it today is really understanding the differences in connections between connections.
Anybody remember what silly putty is?
Yeah.
You do? Okay. So, thank you.
I'm Dawn. I'm an LCSW and I'm a chaplain at Life and Free Clinic in York County. And I've been familiar with the Williamsburg Place and Farley Center for a while.
Wow.
Just to come back for training, CEUs, and to learn more about addiction.
Thank you.
I'm Steve. I'm with the Department of Veterans Affairs out of Hampton, Virginia. I'm here because I'm with colleagues, kind of learning and understanding what the Farley Center is and what they offer. First time here. I'm in food and addictions. I'm not an expert at it, but I'm just here to understand and learn a bit more about it. I'm a clinical social worker.
Thanks for coming.
Keith, Captain VA as well. Work in the homeless program here at the VA. I was talking to a colleague. She mentioned the series, and I thought it would be interesting to come in and learn more.
My name is Kevin. I'm also with the Hampton VA, clinical social worker and case manager. And heard good things about the series of lectures in education. The first year was here last month for the ethics training. I have a good bit of experience with the substance use disorders and addiction, also food addictions, and probably the title of the training question is interesting.
Hi, I'm Valerie Hudson. I'm a registered dietitian here at Farley Center and Pavilion. And we grew up in a very small program here. And I am so excited to finally maybe gain some more insight in the relationship between food and the umbrella of addiction so that I can help our patients understand and kind of figure out how they can deal with this whole issue. So your treatment is to understanding and treatment and defining abstinence.
Got it. Have some eggs. You're really helpful. How about this table?
Hi, I'm John Anderson, and I'm a CSAC. And, food addiction is just one more facet of my profession that I want to gain more experience in it. And so hopefully I'll walk away from here today with a better understanding of it all as far as food and addiction.
Hi, my name is Ebony. I'm also with the Hampton VA Medical Center. I have a background in substance abuse and working with addictions, and most recently I've been working with veterans who have food addictions and who are in the process of getting bariatric surgery. So I thought this would be a great opportunity to come and learn a little more about it.
Yeah. Remind me to talk about bariatric surgery and the assessment process pre-surgery.
Hi, my name is Terry Holden. I'm with Hampton Newport News Community Services Board. I work in chemical dependency as well, but I also work through social services with the Ready to Work program. So I'm working with individuals who may or may not have alcohol or drug disorders, but they have other compulsive behaviors that are getting in the way of their being able to be healthy and lifestyle changes. So I want to learn about information for myself personally, but also stuff that I can use and apply at work with the folks that I work with.
Great.
I'm Julie Clark, and I'm a recovering food addict. maintaining a 200-pound weight loss, and I'm here to learn more about how to be of greater service.
One more table. How about right back there?
This one?
I'm afraid so.
I'm Robin. I'm a licensed clinical social worker and independent contractor in private practice outside of Mechanicsville. I see both mental health and addiction issues, and I don't know as much about food addiction, so I'm hoping to learn some more.
Okay.
I'm Jennifer. I'm a pre-licensed counselor in Mechanicsville, and one of my specialties that I've been focusing on the last couple of years is healthful living, wellness, health, body, food, all that self-image stuff. So this is just more stuff that supports my information about food and better living.
Okay.
I'm Susan Hughes, and I just graduated from the Master's in Counseling program at William & Mary, and I'm a counselor in residency, looking to work with adolescents. And I have some personal interests in food addiction, as well as I would like to learn more to help my future clients.
Great. So we'll go, maybe in part 2, we'll talk to a few other tables. But just as a way of introduction, really, a little disclaimer. What we're going to talk about has really 2 pieces to it. So what I want to do is talk until about 10, when we could take a break, or a little bit after. And that part 1 is the problem. And then part 2 will be the last half of this, which will be the solution, which will address different approaches that we take to eating disorder treatment, and trying to define terms and all of this other stuff. But I want to tell you a little bit about me, other than what's on that sheet of paper, just by way of explaining where all this information is coming from. I sort of wear 3 hats or speak 3 languages in the work that I do, but also personally. There's recovery language, there's insurance language, and there's professional language. And with that, there are personal experiences I've had with eating disorders and professional ones, to leave it at that. And so I'll try and delineate between where things are coming from in this presentation from the research and are more objective, but also there's some anecdotal pieces to this that I want you to know are coming from my own personal experiences, so we kind of blend that together. One last question, because we only went through maybe a couple of tables. How many of you have been affected by an addiction, either in your family or yourself? And the rest have broken arms. Okay. All right. So there's a lot of different language with all of this, but let's see if this will work. We're going to talk about the problem. And basically, I'm going to look at eating disorders, the whole spectrum, through the prism of addiction, or looking at it from the standpoint, really, of having a biological basis, although we know there's emotional and psychiatric components to it as well. And we also know that most eating disorders and a lot of chemical dependency issues come with related disorders associated to it, some predating the addiction or the eating disorder, and some as a result of it. So we'll talk a little bit about that. But I'm also going to talk about anorexia as well as compulsive overeating or binge eating disorder, and look at the spectrum. I just want to add one other disclaimer, and that is, in my professional experience, the poorest way, the least effective way to define an eating disorder is what someone looks like or what they weigh. And I'll make an analogy to that, and you can kind of consider it yourselves. I don't think you could define alcoholism by how much someone drinks, how often they drink, or what they drink. It's what happens to them when they do drink. So there are going to be lots of parallels, hopefully, that you'll be able to connect the dots with, and then you can make up your own minds as to whether you can view an eating disorder through the prism or glasses of addiction. This is a basic assumption. This is probably redundant information for you. You can kind of read it yourselves, hopefully. But here's the distillation of what it means to me. To me, addiction or dependency, whether it's an eating disorder, compulsive gambling, or heroin addiction or alcohol dependency, all have in common the fact that it's a blend of the nature of the person, but also the nature of the substance, and it takes an environment to make the perfect storm. So obviously, all people who drink alcohol aren't alcoholics, and all people who are overweight are not eating disordered, and vice versa. So just something to keep in perspective with all of this. So I will be referring to this as the nature of the person, but also the nature of the substance. Okay. Here's the argument I get from everybody. How can food be addicting? Well, are all drugs addicting? No, but we use the phrase drug addiction, and we're mostly comfortable with all of that, I would think. I'm not sure that food addiction is the best wording or descriptor, but it's what's kind of being used now to describe an addictive relationship with food. I'm more comfortable with food and addiction. It's probably, technically speaking, more compulsive overeating, but it's all language. A rose is a rose is a rose sort of thing. But I'll make this argument to you, and that is, when you delineate addictions, you will say to yourselves that you can live the rest of your life without a drink. You can probably live the rest of your life without a drug. You can live the rest of your life without placing a bet. But food is necessary for life. Well, so's water and air, and I haven't heard of any treatment centers for overdosing on air and water, although that might be an idea. Let's see if we can get to that. How many of you are familiar with the new DSM-5 criteria? Okay, I won't go through it too much, but I think it's interesting that in the psychiatric nomenclature now, they've taken out the word dependency and addiction. Okay, so the group that got together to do this obviously aren't in recovery, but anyway, they came up with similar symptoms or criteria that have existed in the past. It was in DSM-4. It's just now it's mild, moderate, or severe. So I guess people that are at this level of care are severe. Hello, my name is Marty and I'm severe. Okay, so I just want you to keep this in mind. So when we talk about bulimia, we talk about compulsive overeating, binge eating, and even anorexia, whether these criteria will fit. And I'm just going to tell you anecdotally that in my treatment center, we have 20 beds. And if you asked, and then outpatients and so on and so forth, but if you asked 20 people at that level of care whether they have a tolerance, whether they experience withdrawal, and you went down this checklist, I'm going to tell you straight out that about 80% will have 6 of the 7 criteria, and the other 20%, 7 out of 7. It's as high as it would be for alcohol and or drugs. Well, think about it. Tolerance. If you're anorectic, do you keep needing to lose more and more weight to get the same effect? Of course. If you're a binge eater, could you have started out on weekends or once in a while and the frequency and intensity of the binging escalate to get the same effect? It's common sense. So if you go down these, I love the one continuation despite consequences after 3 treatment centers, maybe, or unsuccessful effort to cut back. Anybody ever diet? Okay, just kidding. So a rose is a rose is a rose. Okay? So all these terms in my world or in that language would fit addictive eating. So just so we have kind of the language. This is the one that interests me most. I would say 90%, if not more, of treatment centers that do residential treatment for eating disorders view it, if you want to say a psychological or psychiatric illness, look at it as emotional eating. The assumption being that people that are restricting, binging, purging, binge eating, or what have you on that continuum all have in common that they learn somehow to do these behaviors in a response to self-medicating unpleasant emotions. Duh. True, but is that the whole, excuse the pun, I love the language in this, the whole enchilada? I don't think so. So many food references. Aren't there a lot of food references? Anyway. From the standpoint of addictions, It's not one or the other. I believe in alcoholism. Again, this is personal, professional, anecdotal, that there are some people that are severe alcoholics that you can attribute their drinking, maybe they're episodic or binge drinkers, to 60, 70% emotional triggers, and maybe 30 or 40% is biological or driven by biological factors. But on the other end of the spectrum, there are people that are alcoholics that were hardwired from the get-go that I would say have a 90% biological component by the time they reach treatment. And they'll drink if it's just raining outside. It has nothing to do with emotions. It's blend. It's both. It's not all or none, black and white. Bottom line is nature of the person, nature of the substance. You mix those together and you put it in the right setting and you have a storm. So just want to clarify that. Unfortunately, if you only address one of those issues, what happens? Anybody, bias here, anybody can be put in a controlled environment and do controlled drinking, by the way. You have 80% of people that can do controlled drinking in a controlled environment, but what happens when they leave? They're not doing controlled drinking because they want to. They're doing controlled drinking because they don't have much of a choice. But you could do the same with food. So a lot of people who enter treatment, no matter what the approach is, will do well while they're in treatment. What they've learned is all intellectual. They have no experience in learning what's, normative in terms of a relationship with food. So it could be a little misleading when you see, cure rates, and there is no cure, but you'll have programs saying cure rate 95%. That's bogus. Okay. Nature of the person, nature of the substance. Oh, this is hard to read. I just want to give you an appreciation for how complicated the regulation of appetite and eating is. And I'm just going to go through these very briefly. We'll talk about them a little more. You can ask questions about. There's genetics. About 20% of people that suffer with an eating disorder, and just here's an asterisk. Going back 10 or more years ago, obesity was used as a proxy for what was eating disorders. So the language, when you go back in time, wasn't anorexia, bulimia, compulsive overeating. It was defined by, what your weight was. So if you were underweight, overweight, normal weight, super overweight, and then on and on and on. So a lot of the research was done with people underweight, normal weight, and overweight, as opposed to research that's more recent with eating disorders. So that said, genetically, about 20% of the population that has eating disorders, there is a genetic predisposition. There's a chemical in the body, actually, it's called leptin. Anybody ever hear of leptin? Leptin, to be a metaphor about it, is the brakes. It tells you when you've had enough to eat. It's kind of like a satiety hormone. Okay? Ghrelin is the other hormone. It's produced and located or emanates from the stomach. And it's the gas pedal. It tells you when to eat. I'm oversimplifying, but I just want you to get an appreciation for it. So you have the gas pedal and you have the brake. There are people that, analogy to type 1 diabetes, who were born with a faulty mechanism with leptin. It's called leptin resistance. So theoretically, the more leptin you have in your body, the quicker you will be sated or stop eating. And the problem with that is the more adipose or fat tissue you have, the more leptin you produce. So in theory, people that are overweight, if you want to look at it from that standpoint, or binge eaters, of which about 80% are overweight, you would think they have more leptin, so how could they be overweight? They have brakes that are constantly being pressed, right? Same thing with diabetes. You could be dumping insulin, in type 2 diabetes. You have resistance, it's not working. So it's not that their gas pedal is stuck, but their brakes aren't working. Make sense? So 20% genetically, there's that. You can acquire it or be born with it. That's a simplification of it. Reward circuits. How many of you are familiar with, it's like the topic du jour, dopamine? Anybody? Are you all? Okay. So I'm oversimplifying it, but I think it's important to say. Most of the research going on with addictions in general is looking at reward circuits and neurochemistry. That's where the frontier is, genetics and neurochemistry. We've known for quite a time that dopamine is the feel-good chemical. Serotonin, if you've heard of that as a neurotransmitter, that determines mood, but I don't think people get like a serotonin rush. But if you did a few lines of cocaine, or if you were raised like I was on diet pills or something like that, you would get an explosion of dopamine in your brain. The receptors would just be spewing it out there, and you'd be running around selling matchbook covers, which is probably what got some of you here. Anyway, dopamine is definitely the feel-good reward chemical. The more recent research has found that people with eating disorders have the same response. So we're going to look at some PET scans and MRIs, and you'll see graphically what I'm talking about. But the bottom line is that some folks that are predisposed towards eating disorders, including anorexia, although it's a little bit different, have this subjective response to a drug, and also a subset can have a subjective response to, let's just say, sugar or highly processed foods, junk food, really palatable foods, that's different than someone that doesn't have a problem. So let me segue to really explain this. I grew up with juvenile onset obesity. That's just what it was called when I grew up. But around 8th or 9th grade, I had a best friend named Harry. Some of you may have a Harry in your life or may have had a Harriet in your life. Harry was the type of person that could go to, we grew up in Cedarhurst, Long Island, New York, so we would go to the town diner. He would order a cheeseburger, fries with gravy, because that was in then, and a cherry Coke. And I'd be sitting there feeling really self-conscious, and I would order the normative diet plate, which is a hamburger patty that looks like it was stepped on by a rhinoceros, a scoop of large Courage cottage cheese under a wilted lettuce with a maraschino cherry bleeding on it. You all get the picture? Anybody? Okay, I think they still have them on the menus. Okay, so I'd be thinking in my fantasy world that Harry would be struck by lightning in the middle of our meal, and he'd be flopping around on the floor of the diner, and they'd be doing CPR on him, and I would just push his plate over to mine, finish his food, and then just put the check on his chest and walk out. And then I'd wake up from this fantasy, and he would say, "What's for dessert?" Basically, Harry and I are biologically, physically, and mentally different. And here's where it is. With dopamine as one of the differences, probably acquired rather than born with, but after a while, if I took an Oreo, which someone mentioned as the ultimate bliss point junk food, my experience of an Oreo, especially dipped in Ovaltine, it would be an explosion of dopamine. It would be like a megaton bomb. It would be boom. It would be equivalent to someone who maybe tried cocaine for the first time and got habituated to it. Okay? It would be sensational. With Harry, his would be like a firecracker. It would go boom, mine would go boom. Get it? So there's a different subjective experience from the get-go. And the difference is that my spewing of dopamine and subjective experience of that, much different than Harry's. Okay, and we'll go back to that. Role of serotonin, here's a theory. You can play with it, think what you want with it. It's my contention that a significant number of people with addictions, alcohol, drugs, food, sugar if you want to include that under the food, gambling, what have you, probably suffer from recurrent depression or dysthymia, low-grade depression, maybe in childhood, maybe in early adolescence. And they stumble upon, what's the first thing you stumble upon that could be mood or mind-changing? Right. Yeah. Very good. You all get an A. Huh. How's your insurance? Huh. Okay. So, right, food, right? Later on, it could be drugs, alcohol, and whatever in most cases, but it would be food. If you're suffering from depression, low grade, don't know it, you're adolescent or a child, and all of a sudden food is literally comfort food, acts as a somewhat antidepressant, do you think you'd have a higher probability of getting habituated to that than if you're a Harry and you're not depressed and you're getting a little boom? What do you think? I think the incidence of mood disorders in the addictive population is much greater than in the normal population. Does it mean every alcoholic suffers dual diagnostically from recurrent depression? No. But it does mean there's a significant number of people who need to be treated for both the depression or mood disorder as well as the addictive pattern or relationship with the substance. You all see that? Or can it make sense to you? So serotonin plays a role in all of this because I think genetically and biologically you can be hardwired or predisposed to it, or you can acquire it. Single episode, recurrent, call it what you want. Matter of fact, some of the demographic studies show that some of immigrant populations, Eastern European Jewish population, more prone to endogenous depression than white Anglo-Saxon population coming from Western Europe. So there's a genetic component to that. It gets a little complicated, but it is what it is. Keep this question in the back of your head. So what, now what? Because when we get into part 2, that's going to be relevant. All right, this one's real important. External food cues. Pavlov's dog? Across the board. Can you have a physiological response to an outside stimulus? Of course. Of course. So what would happen if you were born with or acquired a propensity to be more influenced by external cues and oblivious or impaired to internal cues of hunger? Internal cues of hunger are like that Snickers commercial. Very sick. Isn't it very sick? I mean, anyway. Stomach growling, ghrelin, whatever, low blood sugar, feeling tired. You all know, what, to one degree or another, what physical hunger is. Those are internal cues, right? Physiological cues. External cues would be sight of food, talking about food, walking through the mall, pulling up a lounge chair in front of Mrs. Fields' cookies, smell, any number of external cues. Also, we'll call an external cue emotions. Can you learn to associate anxiety with eating, with food? Absolutely. Quick story. I hope I don't forget where I was going with this. Okay. When I grew up, my mother would clean when she was nervous, and if you asked her, to eat, she'd say, I'm too nervous to eat. If you asked me to sit down to dinner or whatever, I'd be the first one at the table because I'd be too nervous not to eat. So emotions can be learned behaviors as well, creating a physiological response. So now think of this. You're sitting in the movie theater. I'm going to keep going back to Harry and Marty. You all right with that? It's, okay. So Harry and I are sitting in a movie theater. This is really dating myself, but remember Creature from the Black Lagoon? In black and white? With a piano player? Just kidding. All right. So Harry's sitting there. I'm sitting there. And across the screen, I really love this because I do this work, you're seeing Reese's peanut butter cups playing trumpet, and you're seeing all this candy at the concession stand as an orchestra. Physical, right? External cues. Harry, oblivious to it. Maybe he's eating some popcorn, right? I'm salivating like Pavlov's dog. Because I learned as a kid to associate going to the movies with what? Candy. Harry might have, but boom, me, boom. So you're getting triggered all the time if you have this piece. It doesn't matter if you're getting triggered because what will function, let's say 75% determine whether you eat or not, how much you eat and what you eat intuitively, will be internally driven. If you're an addict, what's driving you is not internal, it's external, it's learned. So you're 25% internal, but you're dead meat, excuse the pun, enchilada, meat, all right, in terms of external cues leading you around, and you're oblivious to it if you're not paying attention to it. So if I'm 6 weeks into recovery from alcohol dependency, do I want to go to a bar? No. Well, if I'm 6 weeks out of rehab for an eating disorder, do I want to go to Chinese buffet? I don't think so. Well, I do, but I wouldn't. Okay. All right. We talked about ghrelin, leptin. Insulin's another one, just so you know. It's still being studied, but it can go both ways. Part of the role of insulin is to convert food into glucose and then into either muscle or fat tissue. In other words, it's fuel, and it's kind of like, helping your carburetor distribute the fuel. And when it goes haywire, it's not working. So you could be dumping insulin and it's just not working. Or you could be functionally hypoglycemic, which I see with a lot of patients. In other words, they're chronic low blood sugar because the more you abuse sugar, the quicker your blood sugar is going to fall after it gets an immediate rush. It's what some drug addicts will call bumping. This is with food. Okay. Junk food environment. Quick commercial, because we're going to talk about this too. We live in, this is a phrase someone else has used, an obesogenic culture. We can go on and on with all this. Here's the bottom line. Bottom line is, if you go to, which are supermarket here? We have Publix in Florida and Harris Teeter and what's the big one? Harris Teeter? You have Harris Teeter here? Don't you love Harris Teeter? Cool. Okay. So at Harris Teeter, if you go into Harris Teeter, whole food, non-junk food, food that I would prescribe for you is all around the periphery of the store. It's produce, it's dairy, it's all natural foods. 80% of what was not here 100, 150 years ago is in the middle of that drugstore. That was a Freudian slip, but I like it. It wasn't really a Freudian slip. That was good. In the middle of the store. And what ends up happening to us, unbeknownst to us, as tobacco was in 1940, 50, and 60, sugar is now. And by the way, is tobacco an agricultural product? Is sugar? We're in Virginia, right? I'm in dangerous territory. Okay. A lot of people converted. Altiria used to be R.J. Reynolds or whatever, are now buying up Nabisco and food companies. So when you're seeing all these kids eat sugar pops and whatnot, conspiracy theory or not, if sugar is addicting, they're doing the same thing with sugar as they did with tobacco, because it's the same people. I rest my case. Plasticity. How many of you are familiar with neuroplasticity? Easiest way for me to explain this, muscle memory. If you haven't ridden a bike in 20 years, but you used to ride as a kid, you might be a little shaky at first, but within minutes, you would remember how to ride the bike. If you've been an addict, I don't care what your addiction is, you have permanent neuro connections that never forget, ever forget. The problem with a Harry and a Marty is if you reinstitute the substance or the behavior, it's as if you never got off the bike within days. Some people minutes. Some people it's insidious. They wake up in treatment a year later and say, how did this happen again? But it will happen. It's not that you intellectually don't know you're an addict or alcoholic. It's got nothing to do with intellect. It's Pavlovian. Sorry. Trying not to salivate, if you're a dog when the bell rings after 50 times of eating. Not going to happen. Plasticity is permanent. Sensitivity is another term we'll talk about later. I'm going to have to speed this up. You all okay with this information? Okay, I'm not putting you to sleep, am I? Okay. So sensitivity means cross-addiction. So here's Marty, here's Harry. Marty's been addicted to sugar, Harry isn't. Marty's now 16, okay, and someone offers him some white powder and says, this is going to really feel good. Here's a straw, snort it. Offers Harry that, okay? Who has the highest probability of getting into an habituation with cocaine? Marty. It's called sensitivity. If you have this plasticity to alcohol, we know now your brain's going to light up, not with alcohol. It'll light up on nicotine. It'll light up on Percocet. It'll light up on just about anything. It's learned reward. It's learned feel good. It ain't unlearning it. I mean, if you're in recovery, you're probably one of the few groups that really looks forward to, at my age, a colonoscopy. Okay. Not the prep. It's, never mind. Here's a big one with sensitivity, switching forms of addiction. I call it, changing deck chairs on the Titanic. Very few patients come in for treatment that are bulimic that really have the agenda of not binging and purging. They don't want to do that, but they want to restrict. So they trade in one form of the eating disorder for another, because restricting, you can't be too rich or too thin. Everybody here, if you're honest, you don't have to raise your hand with this because I already know. If you could push a button and weigh less than you weigh, you push a button. I don't care what your weight is. So we get a lot of people in that subset that want to switch. And unfortunately, they don't want to do this, but anorectics that are restricting usually morph into bulimiorectics, where they're anorectic weight-wise, but they're binging and purging because out of the deprivation. So they're just, the only thing that's missing is the weight criterion in terms of the diagnosis. Compulsive overeaters, when we treat them and we take them off of sugar, flour, and they're on a whole food plan, and they're type 2 diabetic, and now they're off of insulin in 6 weeks, and on and on and on, they get greedy because their agenda is weight loss, not health. So instead of staying on the food plan, they start to restrict because it's the first time in their life they haven't been driven, to compulsively overeat. So they get greedy. How many alcoholics go back to work and get into workaholism and start missing meetings? It's the same thing. Okay? Cortisol. Cortisol is a stress hormone. In the short run, it's very adaptive, all right? Something happens to your kid, and you develop strength, and you lift the car up, and the kid's saved, and all of that, fight or flight. Very good stuff. It's very adaptive. If you're under constant stress, what'll end up happening is you dump cortisol, and eventually the cortisol is a steroid. It's your appetite will get out of control. If you're anorectic, the cortisol will further your starving, and I'll explain why when we get into the chemistry of anorexia. The cortisol goes hand in hand with weight gain. It's not just that you're eating psychologically because you want comfort food, you're also eating because you have a chemical that's circulating in your body, a hormone if you want, that is making you hungry. Stress. That's just a few of the entities. Yes, a question. Yes.
Back in the 70s, I came from New York, and we were very Freudian in graduate school. And I remember that one of the things to look for if somebody was morbidly obese, had there been some sort of trauma, like a rape, where they would eat, not having to do with the other things you talked about, but to become invisible and unattractive.
Yes. And one of the analytic, because I was reared the Adelphi way. A cigar is just a cigar, but very rarely. I just didn't buy that I wanted to sleep with my mother. That was a little bit much to take. But anyway. The first time I heard that, I saw her and I ran down the block. It was very traumatic. Hilda Brooke. I don't know if you know that name. She was out of Baylor. She was the first analyst to really associate, not get into oral fixation and all of that, but she associated anorexia in particular, but morbid obesity, with trauma, particularly sexual trauma, and as a way of avoiding sexuality. And a side effect of anorexia is you go back to an adolescent chemistry and disappear, right, the golden cage. And then on the other end, you're protected, and on and on. There's credibility to that. I just don't know that that's the most efficient way to treat it. But trauma is a big factor. I'm just lumping it in under stress and emotional eating and all of that. Because if I went through the whole list, really, we'd be here for days.
Now, wouldn't it be important in the initial workup to find out if? Because if you didn't, you could be missing the whole point.
Yeah, we screen for trauma. We screen for, and then under that, is it sexual, is it physical? We screen for any number of things that people normally don't associate with an eating disorder. Cross-addiction, how many eating disorder programs screen for substance dependency? Problem is that about 47% of people at this level of care that are female are high probability eating disordered, if you include compulsive overeating and binge eating.
We'll also have to go from cocaine to sugar because it goes back to
Rebound. Anybody ever take diet pills in the 60s or 70s? Yeah? I used to live in Florida, and so I still do, but near this bus stop. I used to drive my bike to the bus stop, 20 minutes, right? And be very withdrawn and all that. Now, my parents owned a drugstore, which should tell you my whole story. And they got samples from the physicians. This is in the late 60s. So what would end up happening is I didn't know what they were called then. They were amphetamines. I used to call them black beauties, right? So I would get, my pill in the morning, and instead of 20 minutes to the bus stop, I was there in 5 minutes and introducing myself to everybody, and then you get home and you crash. There's a rebounding to benzodiazepines that's very similar, or everything, really. And so the crash part makes your appetite voracious. My parents literally had to lock up or hide food. So, and then you're going to see that with cocaine and methamphetamine abusers, because when they detox and when they're in recovery, food is going to take a central lead in all of this. And it's going to last about as long as the protracted insomnia and the depression, because those neurotransmitters need time to heal. We'll get into that too. I hope you guys brought, like toothbrushes, sleeping bags, and okay. So let's look at the evidence. This is my friend. Can you see what he's eating? Sometimes you can't. I usually get a laugh, but okay. How about this? Study shows that Oreos may be more addictive than cocaine. Good. Breathe in, breathe out. Let's see. My friend told me I have to do this. Yes. Okay, this was on ABC News a few years ago. I'm going to show you. But the point of this is that they're going to say that the research hasn't been validated. It has been validated, but I have to make a honest caveat to this. You cannot make the assumption of translating what happens with laboratory animals as a proxy for humans. Exactly. It's very close in this, but it's not the same. And I'll explain after. It's about 2 minutes, okay?
And a headline tonight rocketing around all day. A closer look at Oreo cookies and a new study tonight that suggests if you can't stop eating them, there's a reason. Nightline anchor Dan Harris.
If you too crave Oreo cookies, you're in good company. We all have our little strategies, of course. Twist them apart, eat the filling first, dip them in milk. But feed them to rats, then things get interesting. That's what researchers at Connecticut College did, and they found that when eating Oreos, the pleasure centers in the little guy's brains lit up as much or even more than on cocaine. And yes, by the way, the rats ate the filling first. Now, to be clear, this study has not been peer-reviewed or published. And as Nabisco, the maker of Oreos, said today, quote, "While it may seem simple to bucket foods as good or bad, the reality is that foods are complex, and encouraging people to enjoy a balanced diet paired with physical activity is most important." True, many experts say the way to fight obesity is more exercise, more fruits and vegetables, and when it comes to things like cookies, moderation. Although, as any lab rat will tell you, that last part is not always easy. Dan Harris, ABC News, New York.
So there is something called the Food Addiction Institute. I think this is a little bit over the top, but I think it's close enough to at least give consideration. And what they're saying, I think I like the phrase that it's a cluster of chemical dependencies for some people. So when you use and research the phrase palatable foods, it means sugar, flour, salt, basically. And there's something in the food industry called bliss point. They spend lots of dollars to find out what the bliss point is. Oreos is a bliss point product. Sugar, flour. The ultimate one is Doritos. That is a real big bliss point one. So bottom line is, if you're an addict, it's sort of like what they used to have, Brompton's cocktail, if you were terminal, which was part morphine, alcohol, usually vodka, codeine, and something else. So it's just the perfect storm for people. Yep.
Is there a difference between like a dependency on specific
Great
chemicals
question.
and like a biological necessity for these things?
Yeah. Let me explain the technicality of it, but it's real good. Let's look at Harry and Marty. Okay. Harry goes in for abdominal surgery. He gets an addict's dream post-surgery. He has a morphine pump, right? So, but he's on it for 10 days. Maybe he doesn't abuse it, whatever. He gets off it. Is he physically dependent on morphine? Yes. Is he addicted to morphine? No. Dependency is only physical. Addiction has one component to it, as I understand it, in addition to the physical dependency: craving. When someone who doesn't have an addiction is deprived of something and they're physically, attenuated to it, they may go through some kind of physical reaction to it, but they don't crave the substance. The craving or drug seeking is the delineation between dependency and addiction. A lot of geriatric patients are dependent on benzodiazepine medications, but may not be addicted to it, but they go through very severe withdrawal. They don't even know what's happening, and they're diagnosed as organic. And what's really happening is they're going through withdrawal. But they're not seeking more Xanax. Put somebody who has been addicted to Xanax, and they'll go through the same kind of withdrawal, but they'll look everywhere to get Xanax. So, same thing. Big difference. All right. We're getting close to bladder time, so I'm going to speed this up a little bit, sort of like when I was on diet pills. Okay. Dopamine we talked about. Here's what I want you to just know about dopamine. When an addict is, when you're doing war stories and talking about good times getting high, that's a trigger, right? Well, it's not only a trigger psychologically, the sight of your substance of choice will create a reaction in your brain chemistry. In other words, the stimuli, Pavlovian-wise, will start into action the craving. Got that? Very important. The two drugs that are most closely aligned neurochemistry-wise with overeating are cocaine and amphetamines. Dopamine deficiencies. Okay. Tolerance. So much to talk about. Anorexia. Let me clarify something. There's research going on in UCLA with a Walter Kay. It's fascinating. He took college students who were volunteer for everything. It's like the Life cereal commercial, they'll eat anything. Well, you pay a college student $10 and they'll give you blood or they'll do whatever. But in this experiment, they hooked them up to an MRI and injected them with I don't know, 7% solution of cocaine or whatever. It was legal. And then they interviewed them after. And the overwhelming majority of the students got high and said it was a very pleasant experience. Okay. Now they took the same number of anorectic patients, did the same thing. 3/4 of the anorectic patients reported the experience was anxiety provoking, was negative. You see, there's something that happens in the brain with anorexia around this that we don't quite understand, but this is a real stretch to explain this analogy. There are some people that love Percocet, opiates, maybe alcohol, maybe depressant side of medications or whatever, or drugs, and don't like pot because they get anxious or paranoid on the pot. So you can't predict someone's subjective experience to a drug. Not totally. That has something to do with it. The other 25%, I find this fascinating, who are restricting anorectics, they get the same rush of dopamine from starving that someone gets from overeating. So you need to delineate who you're treating, because that has ramifications for how you treat somebody. Okay. I just think it's interesting. Why is it addictive? Take those 7 criteria we talked about in the beginning. You'll find it really does fit with anorexia. Exercise the same way. Hedonic eating, if you hear that term, it just means pleasure eating. Okay, this is cool. Can you see this? Kind of? Okay. This is a Harry. Control, right? My middle name, Control. Anyway, this is Control. This is the control subject looking at slides of like pastries and really palatable foods. And this is a concentration of dopamine. Remember we talked about that? A little bit of boom, right? This is a Marty. Can you see the difference? Okay, that's actually what they did. This is just my own take on this. I think that addiction, in my experience professionally and personally, starts out like this. I'm just going to use alcohol, but it could be food too, or it could be bulimia or anorexia. In the beginning, it works great. It's Burger King, have it your way. You're losing weight, you're getting rid of the food, you can have anything you want to eat and you're not gaining weight. I mean, that's nirvana, right? Beginning addiction. You're drinking alcohol, right? You're dancing like John Travolta. You think you are. They're calling 911 because you're having convulsions, but you think you're doing great. All of a sudden you're handsome, you're charming, it works great, right? Middle stage. Yeah, it's still good, but not great. You need more of it. You have headaches in the morning. You're starting to have some consequences, but not enough to really stop, right? End stage. The thrill is gone. Now you're doing it not to get rewarded or feel good, although that's what you hope. You're doing it just to avoid the feeling of not doing it. You're doing it to just barely function. That's the jumping off point. I don't think that's different with any addiction. This is a downregulation of receptors. What I didn't tell you, and we'll break in 5 minutes. 5 minutes, okay? The receptors, right? Dendrites, remember that, all that stuff, and then neurotransmitters, and in the middle, dopamine. When you abuse something, let's say you're abusing sugar or you're doing opiate receptors, whatever. What ends up happening is you build tolerance, right? Neurochemically, what tolerance means is that not that you're destroying the receptors, but your body doesn't think it needs to regenerate them. So instead of having 100 receptors, actually it's 100 billion or whatever, instead of having 100 receptors, now you only have 50 because they don't regenerate. So do you need more chemical or more dopamine to get the same effect? Yes. Here's the problem. You can throw all the dopamine or all the antidepressants at someone. If they have a tolerance and they've downregulated their neurotransmitters, For serotonin, dopamine, norepinephrine, opiates, I don't care what they are, they've downregulated them. They're not going to benefit from the antidepressants anywhere near that if they were 6 or 7 or 8 or 10 months into recovery. Why? Because that's what it takes for these receptors to regenerate. Now, here's my question. You're a heroin addict. You come here, you get excellent treatment. You leave treatment, but you're not going to aftercare. 6 months, 7 months later, let's just say your receptors grow back, right? But the last time you did heroin, you did this much to get this much of a response. You're going to go back to doing this much. What's going to happen? That's right. Very good. 3 more minutes and you guys are going to be on break. This is kind of good. This is resting stage. This is Harry, during the week when he's not snorting cocaine or having a couple of drinks or, whatever. And the red is concentration of dopamine. He's able to go to a movie, read a book, date someone, and have a good time. It's pleasant. He's able to enjoy life the way normal people enjoy life. And biologically or neurologically speaking, the red is a normative high volume of dopamine. The yellow is moderate and green is low. So he's mostly red, okay? Cocaine abuser, in between cocaine episodes, mostly yellow and green. That's why someone on drugs is not happy when they're not doing drugs. They're not going to sit through a movie and enjoy it or read a book. I mean, it's not going to happen. Why? Because neurologically speaking, they had no dopamine. They'd used it up. It would take, a ton of cocaine to get anywhere near there. Got it? So this is the cocaine user. These are MRI and PET scan studies. This is someone who is a binge eater. They're using someone obese as a proxy for that, and they have very little red also. They're identical to the cocaine. This is a happy alcoholic. He has some red, but not a lot. Of course, he only does alcohol. Sensitization and plasticity we talked about. This is fascinating. Maybe you don't find it, but I find this unbelievable. This person has 10 years of being off of sugar, flour, and being what we would call abstinent. Just whole foods, right? Her name is Tenny McCartney. And she runs one of 3 treatment centers, ours, hers, and one other, that use an addictions model in treating eating disorders. That's it. The rest are psychiatric. And so she volunteered for what's called a functional MRI study, which means in real time, kind of. It's a computer program. It's fascinating. I'm not a radiologist, but the technology is like wild. So they fed her a milkshake, just a milkshake, under the x-ray. This is how her brain lit up after 10 years. 10 years. Remember that boom? This is a woman who 15 years ago had gastric bypass surgery. This is a woman who's a bona fide food addict and treats it, has maintained a weight loss, goes to OA, et cetera, and has been abstinent on her food plan, what OA would call gray sheet, I guess. And this is what happened. She was high. She's fine, by the way. She's fine. This is the control subject on the milkshake. You think there's a difference? I mean, how can you deny that this is an addiction? I don't get it. So, sugar addiction, nucleus accumbens, that's your pleasure center. Remember the movie Sleeper? Anybody remember Sleeper? The orgasmic machine in the little ball? Yes, that's where it went. Neuroplasticity. I just want to read this and we're going to take a break. I think that this is by the Task Force, American Psychiatric Association, on chemical dependency. This is ASAM, folks. This is fascinating. Addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. They're thinking not of food or eating disorders. They're thinking of alcohol and drugs. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. This is reflected in the individual pursuing reward and or relief, end stage, by substance use or other behaviors. The addiction is characterized by impairment in behavioral control, craving, inability to consistently abstain, and diminished recognition of denial of significant problems with one's behaviors and interpersonal relationships, 6 marriages. Like other chronic diseases, involves cycles of relapse and remission without treatment or engagement in recovery activities. Addiction is progressive and can result in disability or premature death. Tell me this doesn't apply to bulimia, anorexia, and binge eating. One more minute. Coke. Remember what conspiracy theory? I want you to know that Coke has supported the American College of Cardiology with $3 million donation, Academy of Family Physicians. The sugar industry, this is why I liked Bernie. Anyway, the sugar industry is being bought off. The sugar industry is buying off lots of industries to support themselves. Last thing I'm going to tell you is McDonald's. They supported 90%, they footed 90% of the cost of the last American Dietetics Association meeting, national meeting, was paid for by McDonald's. That's not me, that's an article from the New York Times in September 2015, if you want to look it up. See any parallels? Last quote and we'll take a break. All truth passes through 3 stages. First, it's ridiculed. Second, it's violently opposed. Third, it's accepted as being self-evident. That's exactly what happened with cigarette smoking. That's what's going to happen with sugar. Go to the bathroom, we'll start in 10 minutes. So, here's what we're going to do. I have a tendency to go overtime in all this, and so we have a half hour, or actually 28 minutes. So, I could do 3 days of this. So I'm just going to try and go through this, so we're either going to end up too early or on time. Okay, so here are tenets of recovery, and what you're going to see is basically what we do, in treatment. Now, we offer 3 levels of care, and most places do, which is residential, day treatment or partial hospital, and intensive outpatient. And then our clinicians also have private practices on site, so there's a lot of continuity of care where they can see people individually. But you have a high recidivism rate with addiction. And so even though Joint Commission asks you to do these survey studies, here's a question for you. If I surveyed in the mail 100 graduates of a chemical dependency program, you'd get about 17 to 20% responses back, and you'd probably get responses back only from those people that are still sober. And if you called them on the phone, we know how active alcoholics are totally honest. So they'll admit to drinking or whatever. Well, eating disorders are very similar, only from the standpoint it's a shame-based illness. So the statistics on self-report are I think they're worthless, but that's, including our own, because we could show a 95% success rate, but that's people returning surveys who are doing well. The best indicator I have found anecdotally is people that I hear from attend aftercare. We do aftercare in Richmond once a month, in Philadelphia once a month, and in New York City once a month. Actually, I do it. The people that attend that, not every month, but attend that, attend online. There are 1,000 ways for people to stay connected. So the people that stay connected are the people that are doing well, and the people who drop off the screen, not all, but the majority tend to relapse. So we see, a high rate of recidivism. Yep. Yep. Yeah.
Just a quick question, because I was reading a study that said that people used to smoke and they were not heavy, and now they've cross-addicted to, the sugar, and actually the diabetes and all the complications are as dangerous as the cigarette smoking. What do you
Right.
think about that statement?
I agree.
So what do you think people should do about smoking?
I disagree.
All right, no, but, and they're also getting
Okay,
hooked on.
let me cut to the chase and
Okay.
respond. In 1970, our friends in Japan synthesized a product called high fructose corn syrup and brought it to the United States. You do not metabolize that the way sugar is. Sugar's evil enough. This stuff is the heroin of sugar. So, and then of course we're sold on brown sugar's healthier. Is brown heroin healthier? It's about the same. So with the smoking piece, there's a metabolic component to it, and then there's a behavioral component to it, and we can go on and on with that. You're far better off quitting smoking, but we're not talking about having to bear one addiction for another. If you're vigilant, you can learn to manage that over time. So gaining some weight, even though someone with an eating disorder doesn't want to do that, doesn't mean going from normal weight or a Harry to, being obese. So it's a trade-off. And then over time, your body adjusts, and then, and then you go back to baseline. So I quit smoking. Of course, I stayed on Nicorette for 18 years, but hey, I used to get it from New Zealand. They used to require a prescription for it, and I used to get it overseas in like a big box and whatnot. I chain chewed. So now I'm down to my last addiction. Well, is sugar-free gum. Look, I'm just going to skip ahead. We teach people that there's a triangle of addiction. Start at the top, the most acute. Let's just say it's polypharmacy. Under that, you might have nicotine. Under that, you might have the food or, overeating. Under that, process addictions, workaholism, gambling, sex addiction, multiple relationships, codependency. Under that, you have something else. Your recovery is never ending, in my opinion. You're working your way down toward the base of the triangle. It's called harm reduction. Some addictions you can't delay. If you have an eating disorder and you have a chemical dependency problem, you better treat both either concomitantly or in short order, because the eating disorder will lead you back into the chemical dependency, and the chemical dependency will lead you back to the eating disorder. And if you have one, you'll find out that your chemicals parallel in the service of your eating disorder, like cocaine, like methamphetamine, like killing your appetite with opiates, or working harder with opiates, and we can go on and on and on. So there's a lot to this. Tenets of recovery: you need to identify and abstain from the substances that are addicting. Not everybody is addicted to sugar, sugar flour, white flour, sugar flour, wheat. Now the craze is gluten-free, and on and on and on. I don't know where on the continuum it is. Look, some alcoholics can take Klonopin. I wouldn't endorse it, but they don't get triggered by it. I can't. So it's not all black and white in the world. So you have to kind of feel your way around this. We start sugar, flour, and weigh and measure meals. There is structure. We don't do intuitive eating. The structure is to have something to eat every 3 to 5 hours. And the structure is not like wearing a straitjacket. Food plan's not a diet. It should fit like comfortable clothing, not like a straitjacket. You do have food Nazis out there that ascribe to this. They're usually obsessive compulsive people that weigh and measure a chicken breast to the nearest electron. You know the type, right? And they do it perfectly for like 3 hours, and then they're back to square one. And then you have other people who tend to, throw 4 pounds of beef on a little scale and say it's 3 ounces, Or they put 3 ounces on a scale and they're eating hand to mouth of the refrigerator, because when you're tasting or cooking or standing, it doesn't count. We know who you are. Okay. And we do have police. Okay. You need to address the mood and psychological problems. 80%, I would say, is a conservative number of people that have mood disorders with an eating disorder. It's probably 40 to 60% roughly with a chemical dependency population. How much of that will lift as a result of being abstinent from the drugs or the foods or whatever? You can debate that. Ideally, you'd like to wait 6 months before you make a dual diagnosis, but we don't have the luxury of time of doing that with managed care because we have 6 hours. Need to address the physical issues, right? What about diabetes? We see people with axis 3 issues all the time. Type 2 diabetes can be reversed in most cases, even insulin dependent, anywhere from 6 to about 12 weeks. Eliminating isolation, meetings. Look, you got to be open-minded to this. I'm biased with 12-step meetings, but there's also smart recovery. There are other meetings. There's cognitive behavioral approaches. So it's not one size fits all, you know. But the idea is to be around other people in recovery. And some of the support groups with eating disorders, they spread the disease rather than the recovery. So you got to be careful about the support group. We use a blended model. What does that mean? It's a medical model. We have psychiatry, internal medicine, nursing. We have pretty much what you have here, but we limit ourselves to 20 beds. If I can't remember, which is getting harder, anybody here also put their keys in the refrigerator? Okay. If I can't remember the first name of my patients, it's not going to work for me, or the center. So in our center, it's so intense working with this population that you can't compare it to a chemical dependency population in a one-on-one sense. So anyway, we do a structured food plan, as you heard. We do cognitive behavior, but also dialectical behavior therapy, DBT. I'm just going to give you the condensed version of what that is, harm reduction. It's a variant of cognitive behavioral therapy. Marsha Linehan, who kind of started the movement, very brilliant lady. It's very good stuff, but look, I'm a little bit older. It's not new. Sorry, Marsha. But it's packaged a different way, and I'm all for it. So we do those things. Constructive living. You would need 3 more hours, so I'm going to get into that, and I'm going to give you constructive living in 5 minutes soon. Concurrent treatment of related diagnosis, we talked about that. Very important, in vivo setting. In vitro is the laboratory, in vivo is real life. Like here, we do apartments. Our patients are in a setting where the apartments are in a public area, a set of townhouse apartments within a regular area. They go food shopping with our dietitian. We try to mimic everything in the real world and make it as least restrictive an environment, but still supervise and provide the structure. It's quite a dance to do, by the way, especially if you're a little codependent and patients won't do exactly what you want them to do, and they won't listen. Okay. So the setting's very important. And here's why. The last day you're in treatment, my bias, and the next day when you leave should be the same. Because if you're doing 95% of what you need to do in treatment, you're going to drop to 70% when you leave. Well, if you're only doing 70% while you're there, you're going to relapse, in my opinion. And if you're in a contained environment only, anybody can be fed food at a Renfro or another treatment center, a food tray. Everything's prepared for you, so you leave with a head full of knowledge, but no experience. And if you know anything about addiction, what does intellectual knowledge get you? Get you into treatment. Huh. With an attorney. Okay. Evidence-based treatments, obvious. Daily living skills, we talked about that. And a lot of our patients are first learning how to cook. First learning, and some patients are first learning to trust somebody else preparing a meal for them. Individual family therapy. Here's my bias on family therapy. We see patients, usually younger, that need what I would call a parentectomy. We see other patients whose family needs education, not psychotherapy. And yet we see another, a contingent of couples where they need to understand the risks of staying in recovery, because no relationship, in my experience, can possibly be staying the same once you enter recovery. If you had a relationship pre-recovery, can't possibly stay the same. It may get better, or it may separate, but it ain't going to stay the same. Elements of the food plan prescribed by a dietitian. Nikki, who's been our dietitian for 15 years, one of the most talented people I've ever met in my life. I mean, she's the program, a big part of it. She's great. You have to have the patient as a participant. We don't do doctor-patient, kind of a thing. We're two people trying to help one. So she involves the patients, within the boundaries of the food plan, but they get to pick preferences and shop and do all of that. So we're not dictating everything about food. If you give someone with an addiction no control, you're not going to be doing them a favor. So they have to have a modicum of control. We talked about trigger foods, focus on a food plan, not a diet. Everybody focuses on weight. We don't weigh patients. We weigh them backwards, just so like a blood pressure we can adjust. But weighing patients and having them see their weight just feeds the addiction, right? Anybody ever have weight addiction, scale addiction? Here's my experience with it. You get on the scale right before, you're kind of normal. It's called manic depression. You get on the scale, if it moves to the left, okay, and you've lost weight, you're manic, you're euphoric. Life is wonderful. You get off the scale the next morning and you get on, it moves to the right. You're calling suicide prevention. Now you can't trust the scale because it's not exactly stereo balanced, so you have your grandmother's scale, your neighbor's scale, your scale, and you have a towel rack which you can lay your hand on, and now you can't leave the house until you had a really big bowel movement. You're weighing up, down, right, okay. Someone's not in their head. See me after. Okay. Accountability, very important. All right, here's the meat. The whole enchilada. In Alcoholics Anonymous, there are acronyms and slogans. 99% of what you heard today, you will forget. Sorry. The only thing that we remember as human beings, talk about plasticity, is when an emotion or an experience is attached to it. How many of you remember what you were doing when you heard Princess Diana was killed in a car accident? That's all? Or broken arms? Do most of you remember what happened? Okay. In my case, anybody traumatized by Lincoln getting shot? No, okay. If there's an emotion attached to something, you remember it. An experience, muscle memory, but also cognitive memory. So slogans you can remember. Here's a slogan you can take home with you. There's HALT, hungry, angry, lonely, tired, in AA. I bastardized that, to SURF, spirituality, exercise, rest, and food plan. I can tell you that if you distill the essence of recovery, those are the 4 things that you need to do on a consistent basis. Spirituality, you can define that yourself. It's simply, it's meant to be ambiguous because it's individualized. There's no one definition. But it just means getting out of your own head. For me, it might mean some of my work. When I'm focused on helping someone else and not me, that might be spirituality. Going to a meeting might be spirituality. But you get what that is. But you need to do it, take the S out and take the P and the I out, and you have rituals. You have to be in the rhythm of doing things, I think, in spirituality. All right, exercise. Got to be honest. Most people with addictions, black and white, all or none, feast or famine. They're either running around like a hamster in a Soul commercial, or they're catatonic on their beds doing a finger exercise with a remote control. Some people do that in the course of the same day where they're running around like a hamster and then comatose. But it's about finding middle ground. It's in the service of health and stress reduction, not in the service of losing weight. Because you can use anything here to an excess and turn something positive into a pathological abuse, including spirituality. There's less of it now, but there used to be in treatment centers someone that would hold the big book of Alcoholics Anonymous and walk in a toga and step on a podium, whatever. So there's spirituality, exercise. Rest doesn't only mean getting enough sleep, it does balance between work and play. It means finding a means of balancing physical stress with mental stress. If someone's a construction worker and they're in recovery, they need to have something that they do for rest that involves an intellectual pursuit, maybe reading a book or something. Most of my work is mentally stressful, right? So what will happen to me is I'll feel tired when I come home. I just want to do nothing. That's when I need to exercise. Because for me, rest, balancing out physical with mental, is moving. Move a muscle, change a thought. Ever hear that? Okay. But also work and play. So exercise needs to be play. Food plan we talked about. So here's the deal. If you use this, and remember this is a checklist, if you're having some struggle, not just a bad mood, because feelings come and go, but if you're not doing as well as you would like to do, that's the checklist. Where am I in spirituality? Where am I in taking care of myself with exercise? Where am I with rest? And how am I doing on the food plan? I can almost guarantee you that if one of those things are off, you're off. Easy checklist, right? 10 minutes to explain constructive living. All right, here we go. Most psychotherapy, sorry, wherever you are, most psychotherapy, whether it's cognitive behavioral, whether it's analytically or dynamically oriented, whether it's strictly behavioral, Gestalt, and anything else, they have their place. But in my opinion, connecting the dots of traditional forms of therapy have never helped an alcoholic get sober. So, controversial as it is, that put me in a hell of a shape in my own experience. In 1987, October 28th, a day that will live in infamy, I was invited into recovery by the PRM program in Florida. I was a #1 draft pick, and I was sitting in Jackson, Mississippi, if you've ever heard of a place called Copac, doing hard time there. And one of the dilemmas I had is my whole education was built on dynamic psychotherapy and learning skills of being a therapist, right? This all flew in the face, 12-step recovery, of all of that. However, I knew that it had an appropriate place with marital counseling, depression, phobias, and a whole host of other issues that people will seek psychiatric or psychological care for. And those things are really very good. But it wasn't doing a lick of good with any addiction I had. So I discovered this philosophy that came out of Japan, of all places, and met this professor, don't ask me how I met him, of psychiatry at UCLA named David Reynolds. This was in 1987. And he translated some of the approaches that in psychiatry in Japan that are being used, and then translated it into the Western flavor of it. And just like psychiatry in this country comes from Judeo-Christian components, a lot of this comes from more I guess, Buddhist philosophy or something. None of this has anything to do with religion. It's just that's how it evolved. Okay, that said, 8 minutes. Whew. Okay, here's the deal. This is going to sound overly simplistic, but this is how it works. There's a couple of assumptions here. I'm going to read them off and I'll explain them as best as I can. Feelings are uncontrollable directly by self-will. In therapy, how many of you gone to a therapist before and most of what you're talking about is how do you feel? How do you feel about your mother? How do you feel about your father? How do you feel about this? Feelings have been for a time the holy grail in therapy. I think they're a little bit overrated, but I don't think you can just sit down and will yourself with any certainty to change your feelings. If you're angry, I don't think you could sit down and will yourself to be unangry. I don't think you can will yourself to love someone if you're not in love with them. So feelings are like the weather, they kind of come and go. Feelings have to be recognized, not denied, not pushed away, just recognized as they are. That's not a license to fix them. And what do all addicts do? They insist on fixing feelings. What do all codependents do? What do all people do? Okay. Every feeling, no matter how unpleasant, has a purpose. A lot of feelings tell us what to do. I don't want to have a toothache, but if I didn't have pain in my tooth, I'd never know to go to a dentist. I'd die of a brain abscess. How do you have a point of reference of being grateful if you haven't seen the dark side? Religion is for people that don't want to go to hell, and spirituality is for people who've been there, right? So how do you know what feeling good is unless you have a point of reference? But feelings can also tell you what you need to do. Sometimes what they tell you need to do is keep your mouth shut and do nothing. So, okay. Feelings change over time unless re-stimulated. This one you'll remember because I'm going to tell you a story about it. The first time I started to go from compulsive overeating to an anorectic experience was in 8th grade. And I was sitting in New York in 8th grade, and you know what happens when you're 13 or 14 chemically? Lust, love, girls, boys, sex, right? Hormones? You with? Can't be that long ago. Okay, so Paula Goldberg walks into my 8th grade homeroom. Time was, she was wearing a mini skirt, white boots, and a plaid top. And I went from obsessing about lunch to obsessing about Paula for the next 4 years. Here's what happened. I dated Paula, went to the prom, everything, I lost weight, all that stuff happened in my life. We're going off to college, and once you have something, the thrill can be gone or whatever, or you take it for granted, which happened to me. But we were going to go off to college, so I met her for lunch and was going to tell her, Paula, I really care about you, but it's time we see other people. She said, Marty, something I want to tell you. And I said, well, you know what? Go first. Big mistake. Marty, I really care about you, but I think we should see other people. Within a millisecond, this alcoholic mind went from I really don't love her to this is the biggest mistake in your life. I can't believe she's dumping you. Oh my God, you really love her. And like every Friday night, there'd be Paula Goldberg night. You light a candle, you lip sync music and make believe she's in the audience. You'd pass her house, see a strange car there, and think the whole basketball team is in her bedroom being entertained. Your friends start to run away from you because you're always asking about her. You know what I mean? Feelings fade over time unless re-stimulated. How many times do you keep picking a wound and expecting the result to be different, right? Well, if you apply this to other things, let's apply it to an eating disorder. What's happening to your feelings when you step on a scale? They're being re-stimulated. It's reinforcing the obsessive thinking about food and weight. Do you get the principle? So I call it the Paula Goldberg principle. So finally, when you stop listening to music that, dated your, tears on my pillow, going out of my head, I'm dating myself. All the codependent songs, Can't Live Without You, You Bitch, Look What You Did to Me. That was a favorite. I wrote that one. Okay. I don't know that you can really control your thinking as much as you would like to think. I think cognitive behavioral therapy may be able to influence your perception, but if you tell me to not think about something, I'm going to obsess about it. This is the one that applies in treatment across the board. We're responsible for what we do no matter how we feel. Here's the tagline. Most people have the cart before the horse. If you want to feel healthy, you have to do healthy things. If you want to feel courageous, you have to do courageous things. If you want to feel sober, guess what? You got to do sober things. You are not going to get anywhere if you put as a precondition a feeling. And if you don't think you do this, we all do, you'll say to yourself, I'll go to the beach, put on a bathing suit, exercise, wear shorts, when I feel better about my body. When I feel better about my body. When I feel better about my body. Once you put a feeling as a precondition, it ain't happening. You have to do the next right thing despite how you feel. So in recovery, my bias is the emphasis needs to be on what you're doing, not how you're feeling. And here's the tagline. There's lots of people in recovery that are doing great recovery and feeling terrible. And there's lots of people in recovery at different times that are feeling absolutely great and they're not doing good at all. Feelings are not always, in time, the best barometer to make decisions or to judge how you're doing. Make sense? Okay. This is really a condensed version. I mean, this can go on. I'm going to leave some books here, so if you want to look at this whole lecture in a little more detail and you're interested, you can look at it. These are the levels of care I talked about. Oh, this is important, and then we're going to end. This is what it looks like or feels like before recovery. And this is after recovery, when you're in it. And that's it. Thank you very much for listening.